Dear readers, hello everyone. Today, I will interpret the research achievements of the Department of Urology at Shenyang Hospital, published in iMeta, Neoadjuvant Immunotherapy-Driven Bladder Preservation for Muscle-Invasive Bladder Cancer. Bladder cancer is one of the 10 most common cancers worldwide, with 20% to 30% of cases being muscle-invasive bladder cancer. The traditional treatment for MIBC has been radical cystectomy, which severely affects patients' quality of life. In recent years, with the development of multidisciplinary comprehensive treatment, bladder preservation multimodal treatment strategies have gradually gained attention. The bladder preservation strategy based on neoadjuvant immunotherapy has shown greater potential due to its durable immune activation effect. We conducted a multicenter real-world cohort study using propensity score matching. This study evaluated, for the first time, the feasibility and effectiveness of a bladder preservation strategy based on neoadjuvant immunotherapy compared to TMT and neoadjuvant chemotherapy-based bladder preservation approaches. This study highlights the strong clinical potential of neoadjuvant immunotherapy in bladder preservation for MIBC. A practical, systematic immunotherapy-based bladder-sparing protocol. It is the first to use single-cell sequencing to explore the tumor microenvironment for selecting responsive patients. Based on strict inclusion and exclusion criteria, a total of 163 patients who received bladder preservation therapy were ultimately included in this study. After adjusting baseline features with PSM, follow-up data indicated that the neoadjuvant immunotherapy bladder preservation protocol showed significantly better disease-free survival and bladder-intact disease-free survival than the neoadjuvant chemotherapy bladder preservation protocol. However, there was no significant difference in overall survival between two groups, possibly due to the relatively short follow-up period. There was no statistically significant difference between the neoadjuvant immunotherapy bladder preservation protocol and the TMT group. Univariate and multivariate Cox regression analyses indicated that the response to neoadjuvant therapy and clinical T-stage were independent prognostic factors for the efficacy of the neoadjuvant immunotherapy bladder preservation protocol. Different immunotherapy regimens did not show significant differences in bladder preservation outcomes. Tumors were classified into 3 phenotypes. Patients receiving the neoadjuvant immunotherapy bladder preservation protocol had a higher proportion of inflamed-type tumors. Expression of GZMB was closely related to successful bladder preservation. However, PD-L1 expression levels were not associated with the MIBC. Therefore, the spatial distribution and functional activity of CD8 plus T cells might serve as potential biomarkers for identifying suitable candidates for the neoadjuvant immunotherapy bladder preservation protocol. Additionally, we collected 4 bladder cancer samples and performed single-cell transcriptome sequencing. All single cells were annotated into 9 cell types. The results showed an increase in fibroblasts and a decrease in NK/T cells in the failed bladder preservation group, with minimal changes observed in other cell types. Based on this, we categorized T/NK cells into 6 major types. Overall, the bladder preservation failure group showed a higher proportion of CD8 plus tissue-resident memory T cells. Cancer-associated fibroblasts were classified into 3 categories. The ICAFs, typically associated with immunosuppression, were significantly increased in the failure group, whereas APCAFs were more abundant in the success group. In summary, this study demonstrates the feasibility and effectiveness of neoadjuvant immunotherapy-based bladder-sparing therapy compared to traditional methods, and identifies candidate selection criteria. Key conclusions include, neoadjuvant immunotherapy outperforms chemotherapy and matches TMT in bladder preservation with few effects. Treatment outcomes are similar across immunotherapy regimens if patients achieve clinical remission. Immune phenotypes in the tumor microenvironment, particularly CD8 plus T-cell activity, may predict therapeutic success. Increased fibroblasts, especially inflammatory cancer-associated fibroblasts, and reduced NK/T cells correlate with poor prognosis.